Dr. Bo here. Today we're going to talk about the knee. Oh my gracious, so many knee patients these days with all the walking and the steps and so forth. So let's go over what my evaluation of a lot of knees occurs. The knee is, start at the knee and we'll work our way up to the spine. The knee is meant to move in how many planes of direction? One, right? It's hinged and it doesn't go sideways or it goes one way. So you want the knee to work in that direction. That's the way it's designed to last many, many years. If I bend that knuckle in the knee forward and back, that'd be like the kneecap, and you just have it moving like that. So the knee, above the knee, there is muscles that span the knee. They don't even touch the knee. You can go to the other anatomy guys and they talk about rectus femoris, the vastus lateralis on the side, and the vastus medialis on the inside. And they start at the ASS, which is right here. This is the anterior superior iliac spine, and they attach there. And they run down and go across the knee and attach to the anterior tubercle of the knee. And that doesn't even touch the knee. And the kneecap is sitting pretty much in line with that muscle. And one day I'll have the money to get a better example so I can show it to you. So the rectus femoris, those muscles, vastus lateralis, they are provided with energy from the L3 vertebrae. So 5, 4, 3, and the L3 nerve goes to those muscles that I talked about. And those muscles, if you have, I told you, a left deviation, a left like curvature down here, you can see that's what a lot of people have. It seems like more people have lefts than rights. All day long, I've been seeing people with left. I didn't see anybody this week with a right deviated lumbar spine. I don't even understand that myself. It's probably something to do with my theory about the scoliosis being built into everyone. It goes, around, goes to the right at the top, which is the heart, is over here on the left side. So the scoliosis is almost always away, goes around the heart. If you see somebody with a scoliosis pinching and pushing on the heart, that's usually time to put rods in here or something drastic to save the heart. So most people have a right here, which means they probably get a left here. And my theory is, which I don't have any research for this, but that most people have like a built-in safety scoliosis. Like just in case we were going to have an injury that did that, the spine would bend, it would fold up like that. It would go right and left. And it would have like a suspension in a car. And it would have an ability to do that. If it was straight, if it stays straight and pounded axially, axial is this direction, and it would pound it straight down through the spine, it would crush and put a lot of pressure, a squeezy, on these discs. And they would tend to rupture out or break those annular rings I talked about. So in my mind, my theory is that after 41 years of doing this, that there's a built-in safety, and I don't think I have it. I have a straight spine. So when I get pressure, if I've ever fallen off the horse or fall off, I would actually bang the whole spine together and cause damage. Where a lot of people have that righty-lefty thing, and the spine has a suspension in a lateral direction, which I think might be a good thing. But I'm sure the scoliosis people are saying, no, that's ridiculous. It might be, but that's my theory, is that there's a good reason to have that. And people have that built in. So most of them come in, they have like a left curvature there. And that pinches, and usually the right knee is the one that goes bad. The right knee pinches that disc right there. That hole gets smaller on the right side at L3, goes to the rectus femoris. Here comes the hard part. That causes the rectus femoris and the vastus lateralis muscles to tighten up. And right where it injects into the leg, that nerve comes around and injects and plugs in like a plug, like a toaster, plugging a toaster into the wall. And then that plug gets hot from all the voltage going to that toaster. So right here, there's usually a knot that we work on that distributes the acetylcholine, the neurotransmitter, that transitions from the nerve over to the muscle to make it fire to walk, And that causes contraction of the vastus lateralis, and that puts tension on the knee and that causes the kneecap to move up. Here's the difficult part also. When the kneecap moves up, I don't know if I can show this. I'll try. When the kneecap moves up, it's like a teeter-totter. Let's say we had a piece of, let's use this roller here. No, I'll use something straighter. So we have a teeter-totter, right? And we put the teeter-totter, nothing to do with this red and stuff like here, but you put, let's say this is the leg. This is the leg, and this is the knee. Let's make the red the kneecap. If that kneecap moves up, and if I'm on the teeter-totter at the playground, the seesaw, if you move the teeter-totter toward the guy on this end, he has to now pull harder because he has less leverage. So that would cause the knee to bang up before the lower leg kicked out to walk. So every time you walk, the kneecap being higher because of the contraction of the vastus lateralis and the rectus femoris, bringing the kneecap up out of the center of the teeter-totter. See, if it's here, is nice and balanced, and the guy over here just moves nice and easy. But if the teeter-totter, the kneecap moves toward that person, can you see that he would have to push harder? And he'd actually also have a compression before the foot kicked out. You see? So you get banging of the knee and compression of the meniscuses in the knee because before you get the kick out of the lower leg, you have compression axially up the leg, and that bangs the knee together. So we try to move that lump in the leg. We move this here, and we move the kneecap down to a more advantageous mechanically position. Can you see that having the kneecap down here? This guy on this end would actually have a mechanical advantage. See that? Isn't that cool? Up here, he has to work harder. And that causes banging before you get the kick out every time you take a step at the mall or walking. There's a bang, kick, bang, kick. Again, one of my theories, and it's how I treat my patients and successfully. In moving the kneecap down, again, one more time, gives this guy on this end an advantage. You see, he pushes down, it's more easy for him to walk. But up here, and that tortures the meniscus in the legs. That's one way to look at it. So let's go over that again, one more time. The L3, the curvature, pushes on L3, puts a knot in this muscle here, brings the kneecap up out of the center, then it has to, that provides the levers. The kneecap provides, if you're wondering what the kneecap is for, it provides a mechanical advantage to the leg. So if you had no kneecap, your leg would have to work harder because there's no pivot point. So by having the kneecap in there, it moves, it gives you leverage. You see, this gives this guy up here mechanical advantage to make it easier to kick the lower leg out. So that gets hit, that L3 nerve makes this become hot, contracts it, pulls the kneecap up out of the center. That also makes the meniscus get squeezed. Every time you take a step, the knee is squeezed together. Every time you kick out, take a step, you get a bang before you get the kick out. Not a bang, but you get a compression like that every time you take a step. Where if the kneecap was lower, the pivot point was lower, it doesn't have to do that contraction this way in order to, the foot's down here. So the foot's down there, and then you pull and kick, pull and kick. You want the kneecap just to be down here and just kicking the foot out. This is the foot down here, and your foot kicks out every time you take a step. So you have to stop that pressure in the back, which compresses L3, which goes to the muscles in the front of the leg, which moves the kneecap up, which makes the knee bang together, and also causes a squeezing of that meniscus tissue all the time. Got a lot of kids here today. You're here, I'm pulling up and down the hallway there. All right, like and subscribe. Dr. Bo here.